Let's talk about thromboembolism in pregnancy. Background: 80% of thromboembolic events in pregnancy are venous, 80% are DVTs, 20% are pulmonary embolisms, 0.2% prevalence rate, 10% cause of maternal deaths, pregnancy-associated changes, hypercoagulability, increased venous stasis, decreased venous outflow, compression of IVC and pelvic veins, decreased mobility, coagulation factor changes. There's increase in procoagulants such as fibrinogen, factors 7, 8, and 10, von Willebrand factor, plasminogen activator inhibitor, or something in that. Yeah, plasminogen activator inhibitor 1 and 2, and also decrease in free protein S, which is a anticoagulant. Risk factors: first week of postpartum has the highest risk, then it's postpartum, then it's third trimester, and then this first trimester. Prior VTE has a 4 times risk. Acquired or inherited thrombophilia. C-section has a 4 times risk compared to vaginal. The absolute risk is 3 out of 1,000. Obesity, hypertension, autoimmune disease, heart disease, sickle cell disease, multiple gestation and preeclampsia, anticoagulation medication, heparin, unfractionated heparin, and low molecular weight heparin do not cross placenta, increased renal secretion and protein binding of heparin during pregnancy. Adjusted dose unfractionated heparin is based on activated PTT levels. So table 2 has all the regimens. So for prophylactic heparin, prophylactic low molecular weight heparin, we can do Lovenox 40 milligrams sub-Q once daily. Intermediate dose is Lovenox 40 milligrams sub-Q every 12 hours, or BID. Adjusted dose or therapeutic dose is 1 milligram per kilo every 12 hours. For prophylactic unfractionated heparin, in the first and the second trimester, we can do 7,500 units sub-Q BID, and then in the third trimester, we do 10,000 units sub-Q every 12 hours, unless the PTT is elevated. Therapeutic dose is 10,000 units sub-Q Q2 hours, or more, based on the therapeutic range of activated PTT 6 hours after injection. For postpartum anticoagulation, same dosage for 6 to 8 weeks. More than 6 weeks, you can switch to warfarin. So that was these regimen dosing. Low molecular weight heparin is preferred over unfractionated heparin uh, because there is fewer bleeding episodes, more predictable therapeutic response, lower risk of HIT, longer half-life, and less bone loss. However, you cannot rapidly reverse the effect or assess current effects of with APTT like you can do with heparin or unfractionated heparin. For warfarin, it's a vitamin K antagonist. Warfarin embryopathy occurs during 6 to 12 weeks. So it is avoided during pregnancy. However, if the patient has mechanic heart valves, we can do heparin from 6 to 13 weeks, then switch back to warfarin until close to delivery. If delivery came unexpectedly while on warfarin, the neonate may require vitamin K and fresh frozen plasma. PO direct thrombin inhibitor and factor 10A inhibitors. PO direct thrombin inhibitor is dabigatran, dabigatran, anti-XAs, rivaroxaban. Anyways, these are avoided due to lack of data, and they also cross placenta. So clinical consideration and recommendations. So how is VTE diagnosed during pregnancy? So for DVTs, patient will have pain, swelling. The calf will have a difference in circumference of 2 centimeter or more. These are just suggestive of DVT. To diagnose, we do a compression ultrasound of the proximal vein, as proximal vein DVTs are more likely during pregnancy versus non-pregnant women, because 60% of DVTs are in the iliofemoral vein and 20% in the iliac vein. This can cause swelling of the entire leg with or without flank, buttock pain, or back pain. MRI may be needed if ultrasound is negative and there's still clinical suspicion. Can consider empiric treatment with anticoagulation or repeat imaging in 3 days and 7 days. D-dimer level does not reliably predict VTE in pregnancy due to progressive increase in D-dimer level in pregnancy. PEs, lower exposure with lower fetal radiation exposure with CTA compared to VP scan, less than 0.1 milligray compared to 0.5 milligray. However, both are reasonable. Evaluation for women with history of VTE. We should test them for antiphospholipid syndrome and inherited thrombophilias if they have now had the workup. Candidates for anticoagulation during pregnancy and postpartum. If the patient has an acute VTE during pregnancy, they should be on full dose treatment and also 6 weeks after postpartum. History of VTE and patients with thrombophilias should also be on anticoagulation. Administering anticoagulation. We can take a look at table 3. Table 3. So if you have no history of VTE and no thrombophilia, obviously just no need for anticoagulation during antepartum. Postpartum, we can consider postpartum prophylactic anticoagulation if the patient has multiple risk factors, such as first-degree relatives with a history of thrombotic events or other major thrombotic factors such as obesity, prolonged immobility, and C-section. So if the patient has a C-section and she is obese, it meets this criteria, you should give them anticoagulation postpartum. VTE diagnosed during pregnancy, adjusted dose, low molecular weight heparin and unfractionated heparin. And then 6 weeks postpartum. Single provoked VTE precipitated by the subsequent events such as surgery, trauma, or inability, unrelated to estrogen or pregnancy due to transient risk factors, and no thrombophilia. These patients can be without anticoagulation and antepartum, and they should be on postpartum prophylactic anticoagulation if the patient has additional factors, as mentioned earlier. History of a single unprovoked VTE, as in no identifying precipitating factors, and not on long-term anticoagulation. These patients should be on at least prophylactic heparin, antepartum, and also postpartum. Low risk thrombophilia without previous VTEs. These patients do not need to be on anticoagulation. If postpartum, if they have additional risk factors, they should be on prophylactic anticoagulation. So low risk thrombophilia without previous VTEs do not need to be on anticoagulation. So what are low risk thrombophilias? They include factor V Leiden heterozygote, prothrombin G2210A mutation heterozygote, protein C or protein S deficiency, antiphospholipid antibodies. If they're low risk thrombophilia but with a family history of VTE in first degree relatives, they should probably be on prophylactic dose, antepartum and postpartum. Low risk thrombophilia with prior history of VTE, not on anticoagulation already. They should be on prophylactic heparin. High risk thrombophilia without prior history of VTE, they should be on prophylactic or intermediate dose heparin. High-risk thrombophilia include homozygous factor V Leiden, prothrombin gene mutation homozygous. If they're heterozygous for factor V and prothrombin mutation, or if they have antithrombin deficiency. So if they have high-risk thrombophilia but no previous VTE, they should be on prophylaxis. If they have one episode, they should be on prophylactic or even adjusted dose. 2 or more episodes of VTE, regardless of thrombophilia, they should be on intermediate dose or adjusted dose. 2 or more VTE, already receiving long-term anticoagulation, they should still be on adjusted dose. They should be on adjusted dose. Oh, so if they have 2 episodes but they are not already on long-term dose anticoagulation, you can do either intermediate or adjusted dose. But if they're already on anticoagulation, they should be just on adjusted dose or therapeutic dose. Okay, so alternative anticoagulant, if heparin allergy or history of HIT, or if patient has HIT, 0.1% risk of HIT in pregnant patients. Usually if the risk of HIT is greater than 1%, we recommend platelet monitoring. So most pregnant patients do not need it. Fundaparinux is preferred alternative. It is a direct thrombin inhibitor. It's given sub-Q. Newly diagnosed VTE in pregnancy, if the patient is hemodynamically unstable, or if the patients have large clots or maternal comorbidities, patients should be inpatient. If it's PE, then IV heparin should be started. Anticoagulation monitoring, no need to change weight adjusted low molecular weight heparin when the patient gains weight during pregnancy. When switching to adjusted dose, UFH activated PPT should be checked 6 hours after injection. Anticoagulation around time of delivery. If patient receiving prophylactic dose of low molecular weight heparin, should be 12 hours before induction of labor or C-section, and wait for 12 hours after the neuroaxial block and 4 hours after catheter removal before restarting. If patient on adjusted dose, it should be 24 hours and wait 24 hours after the block and at least 4 hours after the catheter removal. If you're on unfractionated heparin, more than 7,500 units BID, then we should wait 12 hours before and also check coagulation labs. Afterwards, you just need to wait 1 hour after the block or catheter removal. If you're on 10,000 units BID of unfractionated heparin, it should be a 24-hour hold, but afterwards you only need to wait 1 hour before restarting. Patient can also receive protamine sulfate to reverse unfractionated heparin. Even low molecular weight heparin, you can use it, but it's less reliable. So in general, anticoagulation should not be restarted 6 hours after vaginal or 12 hours after C-section. For C-section, I mentioned before, obese patients, or if they have first degree relatives with a history of VTE, they should be on prophylactic dose of low molecular weight heparin postpartum. Women with very high risk VTE, such as proximal DVT or PE in 4 weeks before delivery, we can consider them to be candidates for IVC filters. However, we need to weigh the risk of perforation and migration of the filter. Postpartum anticoagulation, if more than 6 weeks of anticoagulation is needed, we can switch it to heparin. Iron needs to be 2.5 for 2 days before stopping the heparin bridge. Breastfeeding is okay on heparin or warfarin as they do not accumulate in milk.